greater cognitive impairment. So we have all these double-edged swords that we're now applying to older patients. Here's an interesting single case report, but this is something you always want in the back of your head. This was a 65-year-old, had been on valproate for epilepsy for 15 years. The last 2 years, the brain is not doing very well. Cognitive function down, gait's getting unstable, looks like ventriculomegaly, the ventricles look like they're getting bigger, cortical pseudoatrophy. Whoa. Well, she'd been on, or he'd been on valproate for 15 years. Couldn't be the drug, could it? Well, look what happens. 4 months after discontinuation, cognition and gait had normalized, and ventricular size had shrunk down. These are rare, uncommon reports. But they're the kind of report that sort of gets you never expect it to be. Not many drug interactions with valproate. That's sort of nice, except as people get older, protein binding decreases. Another problem with aging, where albumin levels go down, free drug levels go up. And that happens with valproate. The total valproate level stays the same, but the free drug level goes up. And anything good or bad that's associated with that will not be reflected in total level. So keep that in mind in the elderly. And then, this is a drug with not many drug interactions, which is rather nice. Avoid aspirin. Now, somebody should say, well, look, a lot of people take baby aspirin a day, half an adult aspirin a day, to keep their heart working. Well, should you avoid it? I don't think so. But keep in mind that aspirin does two things that are possibly negative. One, platelet function goes down, which could be good or bad, but valproate can also decrease platelet function. And two, in the presence of aspirin, free valproate levels go up. All the rest of these interactions I've either talked about or I tell you, if you're combining valproate with carbamazepine, you have a very complicated life. I didn't say much. Well, I can cover atypical antipsychotics as easily as everything else. There are no published controlled studies in the elderly bipolar patients. At least none that I could find. Again, we're basing our treatment decisions in the older patients on mainly data extrapolated from the young. And there you go. And there are some drawbacks to atypical antipsychotics. And they vary enormously across that class of drugs. So keep that one in mind. We all know the metabolic effects. This guy was a little old. Says, I've worn a 34-inch waist ever since I was a teenager.